Good evening. Welcome all to our second webinars in a series of multi-professional reporting webinars jointly run by BNMS and Society of Radiographers. I'm really delighted to have so many people registered tonight for this webinar, and I am chairing tonight as a BNMS president together with Tristan Barden, who is, as you probably know, qualified radiographer and the head of the lead superintendent, advanced clinical practitioner for nuclear medicine in Maidstone and Tunbridge-Wells NHS Trust. Tristan pioneered advanced practice in nuclear medicine field, and he completed his postgraduate training in nuclear medicine in 2008, taking charge of his own department in 2010. Tristan is currently lead superintendent for nuclear medicine, and he also completed his cardiac stress leader postgraduate qualification. So he's one of the first running service from a really advanced clinical practice in nuclear cardiology, and he maintains strong interest in extended role for non-medical practitioners in this field. So he also is example of how really hard work can really bring a lot of happiness and multi-professional working in the field, but also example of someone who really worked for a long time to achieve his goals. So he does enjoy teaching and educational, really very highly educationally recognized in his field. So basically, he enjoys helping training, educate the next generation of radiographers, and promote nuclear medicine as a key growth area for the future. Tristan will introduce our speakers tonight, and we will then later on have a time for questions and answers. And please put your questions in a chat box during the webinars. So I also want to thank our really fantastic sponsors who enable us to promote nuclear medicine and education in this field. Now, Tristan, please, can you introduce our speakers? Thank you.
Thank you very much, Sabina, and welcome everyone to the BNMS Multidisciplinary Reporting webinar on the implementation of REALM in nuclear medicine. I have the pleasure of introducing our speakers tonight. Dr Emma Owens, who's a general radiologist with an interest in nuclear medicine at Eastbourne District General Hospital. She is the current BIR SIG member for nuclear medicine and is the chair of the Trust's Radiology Realm. Emma has also co-organised the RCR Realm Conference in 2025. 2025, yeah, that's correct. We're also joined by Dr David Little, who's a consultant radiologist in Bath with a special interest in radionuclide radiology, and he's currently Medical Director for Education and Training for Clinical Radiology at the Royal College of Radiologists. He's also co-author of the BNMS Guidance on Nuclear Medicine Events and Learning Meetings. And without further ado, I will hand you over to David to take us through his first presentation for the evening.
Thank you very much. Just bear with me whilst I share my slides, which you can hopefully now see. So yeah, my name is David Little. I'm a consultant radiologist in Bath, and I'm going to talk to you a little bit this evening about nuclear medicine events and learning meetings experience from a nuclear medicine department. We've been running these meetings in Bath for a couple of years now, and I have presented the BNMS on this previously, so apologies if some of the slides look familiar. It's something that we won the Innovative Team of the Year award for a few years ago, and as Tristan said, we've written some guidelines on this for the BNMS as well. So it's a bit of a rhetorical question, really, to start us off. I'm not expecting anyone to answer it necessarily in the chat, but I just want you to think about for a minute how many of you have made some kind of error at work. Now that could be anything. Could it be a reporting error, if that's what you've been doing, or it could be anything else. And the reason I ask this question is because it's really important, and the first step in learning from mistakes or errors is being able to acknowledge that we all make them. And So that's the kind of key, and this is particularly important in a multi-professional environment where sometimes there can be a little bit of a hierarchy, and it's really important that even the most junior member of the team knows that we are all human and we all make mistakes. And on that basis, I'm going to share a mistake that I made with you. In fact, it's a mistake that I've made more than once, but we'll come back to that. It was in the middle of a busy day at work. One of the admin team had called me up whilst I was reporting some acute CT to ask me to vet some outstanding PET CT requests because they had some slots available the next day. And being the dutiful radiologist I am, I offered to do so quite quickly because I was also trying to report the acute CT. And this was one of the requests, a 65-year-old post-treatment patient for lymphoma. So yeah, I kind of skim read this quickly and vetted it as a PET CT from vertex to proximal thigh with IV contrast, which is our standard post-treatment lymphoma protocol. We do the scan and I come to report it and I realize that I've made a bit of an error. I didn't leave it up for very long, but the very astute of you might have spotted that buried in the clinical history, it says the patient originally presented with a rapidly growing soft tissue nodule in the right leg. But unfortunately, we haven't scanned all of the right leg. We've omitted the important part of the scan. Either I've been vetting too quickly or just clicked the wrong button on our system. But either way, we need to get the patient back. We recall the patient, we apologize, scan the legs. And other than a bit of extra FDG in terms of radiation, there's no harm done. So what can we learn from this? Well, I think there's probably quite a lot we can learn from this, but traditionally in radiology, we have the radiology events and learning meeting or realm meeting that you may have heard of. But the difficulty there is that's focused almost entirely on the report. And in Bath, and again, I'll come onto this a little bit, we have a realm meeting in radiology every week where we meet on Friday and we talk through all of the radiology reporting errors and discrepancies and occasionally some gold stars as well to try and help us learn. But the focus is just on reporting. And it obviously that's the kind of theme of this webinar. But I think in NM, we're a close-knit multidisciplinary team and we can learn more from each other, not just on the reporting, but actually at any stage of that patient pathway. We know that errors can happen at any point in that pathway, from referral, might be the wrong patient referred for a scan, from vetting, like the example I shared, from booking, we might give the patient the wrong instructions, we might do the wrong scan or inject the patient with the wrong radiopharmaceutical, and then we might get the report wrong. Actually, when you break all of these processes down, healthcare, and particularly nuclear medicine, is a pretty complex business, and it's a wonder that we ever get anything right in a way. So what did we do in Bath? We established a nuclear medicine events and learning meeting. It could definitely do with a snappier title, and if anyone's got any ideas, then post it in the chat, and I'll catch up with that at the end. And this was very much modelled on the RCR realm or radiology events and learning meeting, but with two kind of key differences. Number one, it's multi-professional. So yes, in the realm, there's sometimes some reporting radiographers that come along and join us, but that's only a tiny part of it really. The rest of it is just radiologists. But I think in nuclear medicine, we have a real opportunity because we work so closely as a multi-professional team to benefit. And this has been really interesting because I think we can all learn from each other. And having run this process for a couple of years now, often different members of the team will offer very different solutions, but equally valid solutions to issues, particularly kind of systemic issues. And that means that actually an error in one part of the pathway can potentially be picked up and corrected by any member of that multi-professional healthcare group. The other key difference from the realm process is that we look at the whole patient pathway. So not just the report, but everything from referral through to report and beyond. And we also include other things like near misses and gold stars, which I'll come back to. So I'm going to touch a little bit on how we do this in Bath. It is just an example. You don't need to follow it, obviously, but I hope it will encourage you to consider thinking about this in the multi-professional environment in which we work. So our meetings are truly multi-professional. We have radiologists and physicians, we have nuke med techs, we have radiographers, we have HCAs or assistants, we have the physicists, and we try and include the admin staff as well. So it really is the whole nuclear medicine team, which is truly multidisciplinary. In terms of frequency of meetings, there's definitely no one size fits all here. It depends, I think, on the size of your department to an extent. We try and meet quarterly. Usually that's tagged onto a departmental training afternoon, and we meet for about an hour and a half. It's really important to try and identify that dedicated time, which I appreciate can be difficult. We're lucky in that we've been able to tag it onto a training session that already existed. I think setting that up from scratch would have been more challenging, but it's really important that all the members feel that they can attend. We've experimented with a couple of different methods. We set this up around the time that COVID happened, or just before COVID. So we did the first meeting face to face, and then it all went virtual. And now we've kind of settled on a hybrid sort of meeting, which is a bit of a hangover from COVID, but it means more people can attend virtually. And I think there are pros and cons of both approaches. But we've adopted Teams quite nicely for people submitting cases for discussion, and they can be added to a shared spreadsheet anonymously, which is quite helpful. We run the meeting in a very structured format. So each case or event, if you like, is presented in the same structured format, and we aim for about 10 to 15 cases per meeting. So we discuss the situation, what actually happened, describing the incident or event. Then we have some discussion around it, thinking about why it might have happened, what were the root causes, were there any contributing systemic factors, are there any potential areas that we could improve? And out of that, we draw some lessons learned and extract some key insights and hopefully try and prevent these things happening again in future. And some, but not all of those, will lead to actions for us to implement to prevent these errors happening again in future. And unlike the realm process, we actually document not full minutes, but key kind of lessons and action points for us to go back to make sure that we've implemented them. One of the founding principles of this realm process or NML process is anonymity. It's really important that all staff members feel they can contribute without fear of being victimized. This is a learning process. Now that can be easier said than done in a small nuclear medicine department where often everyone knows kind of when an issue has happened anyway, but it is important to try and maintain that. The only exception being gold stars, which are an opportunity for us to celebrate when things have gone right. Well, and getting the culture of these meetings right is absolutely vital to the whole process. As I've said, this is not about blame. It's a non-punitive process. It is entirely focused on learning. Language is really important. It's really important to avoid phrases like, "Oh, that was a really bad miss," or "really bad error." It's really important that people feel safe to contribute, and that we try and get rid of that hierarchy as much as possible. So whether you are the professor of nuke med with 25 years of experience, or a new reporting technologist, or a band 3 admin, whoever you are, we all make mistakes. So leveling that hierarchy and making it possible for people to speak up is really what this meeting is about for me. And if you get that culture right, then the learning should occur naturally. Gold stars are an equally important part of the process. And we really have to try people to submit kind of gold stars, but it's become more embedded now, and it's a useful opportunity for us to share examples of good practice when something's gone really well. Either an individual win or a team success, both of which can be celebrated, and there's plenty of evidence that actually positive feedback is much more effective in team building and encourages good performance. So it's something really to think about. One of the really important things we do is look for themes. What are the common errors that crop up over and over again? We try and look at that on an annual basis, and we've spotted a few themes along over the last few years, one of which is definitely vetting errors. Another is reporting errors on PET-CT in the kidneys. And these are areas to kind of focus your QI or quality improvement activity on. You may or may not be aware of the professional duty of candor. If you're involved in reporting, it's really worth reading this document from the RCR. And it's really important to separate the learning process from other formal governance processes that might happen. And this can be difficult sometimes. Lots of the cases that we discuss might also require standard trust governance processes like DATICS. And this duty of candor legislation requires that following an unintended or unexpected incident, in the opinion of a healthcare professional, that it could result in severe harm or moderate harm to the patient, then we need to acknowledge that with the patient and apologise and be open and honest. And this is a useful piece of documentation from the RCR that sets out how we can potentially do that in radiology. And there's lots of crossover with diagnostic nuclear medicine as well. So if you are reporting, then it's worth having a read of this. So back to my vetting mistake. We discussed it at one of our nuclear medicine L meetings. Turns out, actually, as part of the process of booking a scan, lots of people read the request. The radiology assistants often read it. The technologists usually read it at some point. So really, we emphasise during this discussion that if anyone thinks a mistake has been made by a radiologist on the vetting, then to err on the side of caution and check with a radiologist. A few months later, I made exactly the same mistake again on a different patient this time. But this time, following the discussion at the NML, one of the booking team called me up to double check the vetting. And they prevent the same mistake happening again and yeah, save my ass basically. I submit a gold star to the next NML for them for their great pickup, and that reinforces the message. Meanwhile, I go away and reflect on how I've managed to make the same mistake twice. And if we think about why error happens, you'll all be aware of the Swiss cheese model. And what I think these meetings do is fill in some of those holes in our team. They fill in the team's knowledge, give them a better understanding of that whole process, whether it's reporting or vetting or a procedural thing. And that helps us all try and prevent some of those errors. Maybe I should fill in that one of those individual holes and stop vetting. That might save a few errors. And these are a few of example events that we've discussed at one of our NML meetings. It's just part of the agenda, I think, from our last meeting, but one. And as you can see, there's events from every stage of the pathway. So it might be a reporting error in PET, for example. It could be we've injected the wrong tracer. We didn't follow the correct prep for the scan. We had a gold star for a technologist who saw some kind of planar and suggested doing a SPECT-CT. We also get queries, can you just tell us a bit more about parathyroid imaging? And that's useful because it fills in gaps in knowledge for the whole team. We've had an incorrect patient scanned due to referrer error. And then we had a sentinel node SPECT-CT that was done on a day that there was no radiologist available to report it. And there was learning from all of those events to think about how we could try and prevent them. I mentioned at the beginning that the BNMS have published some guidance on nuclear medicine events and learning meetings. This is available from the BNMS website. It is relatively focused on the process that I've just described in Bath, although we did have some input from teams elsewhere. And yeah, I would recommend any of you that are thinking of setting this up, whether just for reporting or for the whole patient pathway, to have a read of this guidance. So to summarize, we know that errors and discrepancies and issues are a really powerful tool for learning, potentially for the whole team. If you don't have this kind of learning in your departments, then I would strongly encourage you to think about how you could establish it. And it may be that you want to mirror that RCR realm process if we're focused on reporting, but I think there's an opportunity here for us to work really collaboratively and get the whole department together and learn from each other in that multi-professional environment, and thinking about that whole patient pathway. Culture is absolutely key to the whole process, and yeah, without good culture, these meetings potentially won't work. And it's really important that we separate these meetings from those formal governance processes, because what we're talking about here is an opportunity to learn. Yes, those governance processes may have to happen in parallel, but that's fine. They can happen alongside these meetings. Just want to say thank you to the de-anonymised team in Bath for all their help and input into this process. The feedback from the whole team is that it's been a really useful and valuable experience for them. And yeah, that's the end of my talk, and I'm happy to take any questions in the Q&A at the end of the webinar. Thank you very much for listening.
Hello and welcome. Thank you to the BNMS for asking me to give this talk on NMELM. My name is Emma Owens. I'm a consultant radiologist with an interest in radionuclide radiology. My other special interests are gynecological imaging, particularly MRI, and I also report whole body MRI. I'm a member of the BIR Specialist Interest Group in Nuclear Medicine. I was a long-standing member of the Real newsletter panel, for which I finally left this year, but I have just co-organised the national RCR realm meeting this year. I'm a chair of I chair our trust radiology realm as well. I'm going to talk a little bit about how reporting discrepancies can occur. I've got an example of what happens when things go wrong, some examples of why additional imaging might be helpful, and I'm just going to give some tips using cancer bone scans. I'm not going to talk about how to run an MRI. So I'm just going to give you some figures for litigation. So the NHS-LA, which is now NHS Resolution, gave these specialty figures from 2018-2019. And you can see that for radiology, the percentage of the total number of claims was about 4%, only equating to about 2% of the actual amount spent in 2018-2019. But if you have a look at this Freedom of Information request for claims specific to radiology, you can see that whilst that was just a snapshot of 1 year, the number of claims has massively increased from 2009-2010 to 2019-2020, and the amount paid out has increased by tenfold to just under 58 million. And just remember that there's often a delay between usually a several year delay between the claim and the actual payout. So the radiology error rate is thought to be approximately 4%, and that's been pretty standard for many, many years. However, there was one very good study which suggested that the retrospective error rate is probably actually closer to a third. And that is if that was for radiologists reviewing their own CT reports and other people's CT reports, and it was pretty much the same for both. But if we stick to the accepted expected real-time error rate of about 4%, if you assume that there's 1 billion radiology investigations worldwide per year, that's 40 million reporting errors per year. In the UK, we get there were 46 million imaging tests, roughly 22-23, which gives not far off 2 million errors. And if you come to just my trust alone, we had 4,221 nuclear medicine patients, and at 4% that would give 169 errors. So with 2 reporters, we should expect to have approximately 85 errors each, and I have yet to be informed of any of them, so we're not picking them up, but they will be there, we're just not identifying them. So how do we prevent these things from happening? So there's many aspects to the report. Obviously you need good quality images, and then you need to interpret it accurately. Your report needs to be well written, clinical and actionable, and then it needs to be reported in a timely manner and delivered to the right person who can then act on it. So there's many aspects of this report. It's not just about reporting, although I'm going to talk more about reporting than anything else. And so your accurate interpretation, there are many systems in play here. So and this is all about your patient selection to start with. So you've got to have the right patient, you've got to get the right clinical information, you've got to vet it appropriately, you've got to give the right dose to the right patient at the right time, and just do the right imaging. There's lots of things that might affect your interpretation. There's multiple biases. And then your report is really important. The wording of your report is incredibly important, and getting it to the right person. And then you've got factors such as fatigue and being annoyed, which actually do affect your report more than we would give credit for, probably. So perceptual error is the biggest cause of radiologist reporting errors, and it's thought to account for approximately 40 to 80% of our reporting errors. And this is where you don't see the abnormality. So it occurs during the initial interpretation, and the causes of this are poorly understood. There are many potential causes, as you can see, but often there isn't a cause. We just have missed something. And when you go back, when you have them shown to you, you go back and you look at the imaging and you go, how in the world did I miss that? And the answer is we don't know, but we did. Interpretation errors are where the abnormality is identified, but we've either misunderstood the importance of it, or we haven't correctly relayed the importance of it. And so this is something that is easier to rectify, because often it's just due to our lack of knowledge, or these are things that we can train better for, or there may be a cognitive bias, or we've got the wrong clinical information, so we've gone down the wrong path. And then the other really important one for the interpretation errors is actually somebody said, oh, it's this, and we've said, so we've just reported it, said it's still there, it must be the same thing, haven't we thought about it, and continued to propagate this error that was made right at the start. I'm just going to talk a little bit again about communication errors, which are becoming increasingly important in litigation. So these are often not thought to be radiology errors, but they are part of they're part of an overall complaint or an overall issue. And this can be due to the wording in the report. We've given a long wordy report with no conclusion. We haven't highlighted the significance of particular findings. We haven't given critical findings, and a lack of conclusion is actually very important. The other communication errors are delays in reporting and delays in reading the report. And I'm just going to highlight the Academy of Medical Royal College's alerts recommendations. And whilst it's probably less critical for nuclear medicine, because this is often second-line imaging, there will be some recommendations in here that are relevant. And before I move on to talking about bone scans specifically, I'll just also bring this to your attention as well. So this is a website. This is called Civility Saves Lives, and this is actually aimed at improving communication between healthcare professionals, and specifically with regards to being nice to each other. And some of the facts and figures in here are really interesting. So, for example, the written word, so an email or a text message or something like that, only slightly more than half of it is understood. So we've probably all done it, written an email or a text message, and it's been completely misunderstood and misconstrued, and it's all gone a bit wrong. Whereas 3/4 of people will understand if you pick up the phone and talk to them. So it can be really important just to speak to people. And the rude surgeons impair anaesthetic performance is really interesting. So they had a polite surgeon and a rude surgeon, and observed the anaesthetic performance, and the percentage of anaesthetists performing at the expected level was way higher if the surgeon was polite, and this was despite the anaesthetist thinking that their actions were pretty much the same. So being civil is really important, and I definitely have sat there and been slightly irritated by something, but if you do get like that, it's well worth just taking a breath, counting to 10 and thinking, this isn't good for the patient. We need to just step back from this. So I'm just going to talk about bone scans a little bit. You all will know it's a technetium labeled bisphosphonate, binds to hydroxyapatite at a bone formation. So the degree of uptake is influenced by both osteoblastic activity and regional blood flow. So it's got a really high sensitivity, but not such a great specificity. It's a bit difficult to determine the sensitivity and specificity of bone scans. Most people have stopped writing papers about them because PET's much more interesting. But if you look at all the papers that are around and the information that is around, and just from reporting them, we know that they're actually very good for sclerotic disease, and they're not very good for lytic disease, and we really shouldn't be using them for myeloma at all. Some places use only planar imaging, some places use SPECT CT on everything, and some use a bit of both. The SPECT does increase the sensitivity and specificity a little bit, and we actually use SPECT CT for all of our cancer bone scans. Two bed SPECT CT. And we all know that the tracer uptake is non-specific in isolation. So in our institution, we pretty much only do them for prostate and breast cancer, and the majority are for prostate cancer. And so these are often elderly men who have many reasons for their uptake. So yes, we're looking for bone mets, but they've often got at least one joint replacement. Many of them will have rib fractures. Most of them will have degenerative disease to some degree, and they might have some of these other causes for uptake as well. So what happens when things go wrong? It's not usually an isolated incident, it's usually multiple points of failure, and it can be catastrophic for the patient. It's not just their prognosis and their treatment options, often the psychological impact is massive. So obviously, if you've got a really easy scan, for example, with bones, multiple random foci of tracer uptake, which look like mets, it's going to be mets. You don't need additional information, but actually, if you're not sure, you need to use all the information available. There's usually some additional imaging which may be helpful, and you might need the bloods and clinic letters, etc. So this lady in her early 60s had breast cancer, and this was her staging bone scan. She had an isolated femoral lesion, as you can see, and we said it could be an isolated met. It's unlikely, not the right pattern, but it could be an isolated met, or it could be something else. Do a plain film to start with. So we did the plain film. There is a tiny lucency that's very hard to see on these images alone, and some periosteal reaction. Then we did an MRI, which showed pretty much the same thing, a high stir, low T1 lesion with, again, periosteal reaction. So both of these appearances are non-specific, but rather than reporting the MRI as non-specific, we reported it as a metastasis. And so from that point on, she was treated as metastatic breast cancer. So she started with just hormones, then she had chemotherapy, and she had lots of subsequent imaging, which was complicated by poorly controlled epilepsy, resulting in repeated falls with multiple fractures. So her bone scan kept on getting multiple random areas of uptake, which kept on coming and going. So her imaging was difficult. But on this particular subsequent bone scan, you can see she's got a left clavicular fracture as one of her fractures, but her femoral lesion had increased in size. We repeated the plain film to make sure that there wasn't a pathological fracture or something, and despite the increasing periosteal reaction, we reported this as a progression. So at this point, she was treated with radiotherapy. Post-radiotherapy, she developed an effusion, and this was her plain film with even more periosteal reaction. And at this point, she had an MRI, and somebody said, "Are we sure that this is a bone met?" And so we went back over all of her imaging, and actually at the time of her staging bone scan, she actually had a raised CRP, and a couple of weeks before was being investigated for a PUO, but none of that information was available at the time. Actually, when you go back over the reports, most of the reports were actually fairly equivocal, but the request forms pretty much all said metastatic breast cancer, query progression. So her final diagnosis was an acute on chronic infection on the background of osteonecrosis, which we had caused with the radiotherapy, and there was no malignancy. And obviously she had a lot of unnecessary treatment, but this went on over a period of several years. And when I spoke to them to ask if we could use her imaging for learning purposes, they were still extremely devastated by the whole events, and this was many, many years later. It's just really important we try and get these things right. So just a few bone scan top tips now. So number one, not all tracer uptake is malignant, as demonstrated by that lady. Here's some other nice examples. So rib lesions are really common in our, particularly in our prostate cancer patients, I think, because they're older. They've often got rib fractures, as you can see. So you can see this one man, he's got a rib fracture and a benign rib lesion, probably an enchondroma. These little tiny lucencies with a sclerotic rim can also be seen with treated bone metastases, but on a staging scan this is a benign lesion, and often you see that they're unchanged over many, many years. We've actually had a number of isolated skull lesions, so you can see there's a fibrous dysplasia and a meningioma, and this man has Burhol's. Here's a nice example of an osteophyte, another man with prostate cancer. So he had lots of, you can see he's got degenerative changes, and then he's got this focal uptake in his lower lumbar spine, which you can see on the SPECT CT is just his osteophyte. So that was quite nice. So number two, top tip, not all bone metastases or malignant bone lesions take up tracer. So, as we've already said, we shouldn't use it for lytic metastases or myeloma, really, and particularly the infiltrating lesions. The bone scan is not particularly helpful. And so this was a young woman with breast cancer and back pain. So you can see on the bone scan there's a little bit of increased tracer uptake, which probably would have dismissed as not very much. But because she had back pain, we suggested she had an MRI. And you can see that actually what she's got is malignant spinal cord compression. And so we shouldn't really be using it for these infiltrating metastases, but also we shouldn't really be using it for focal symptoms. Number three, an isolated focus of tracer uptake will often need correlative imaging. Pretty much all of the examples I've already shown you needed correlative imaging. But I've got a couple of examples here of two different ladies with breast cancer. So this lady, you can see, has an isolated shoulder lesion. You can't see very much on the CT. There's possibly something a little bit sclerotic, but it's actually very difficult to see. But then you can see at least on the SPECT CT that this lesion is distant from the glenohumeral joint. So it's and actually that joint is pristine. So it's not degenerative change. And when we go on to the MRI, you can see that actually this is a bone metastasis, and this was an isolated bone metastasis. So similar lesion, but this one turns out to be in the spine of the scapula. This lady, another young woman with breast cancer, has had all the imaging going. She's had, and it's not visible on an MRI, not visible on our whole body diffusion weighted imaging. And it's not visible on a PET CT, so it's probably benign. We don't know what it is, but it's probably benign. And we've followed it up, and so far nothing has developed. So a bone scan cannot characterise a focal lesion. So I don't know about any of you, but I get a lot of requests for things saying there's a thing on this CT or plain film. Can we have a bone scan to determine if it's malignant? And obviously we can't tell them that. All we can tell them if it takes up tracer or it doesn't, and that's completely unhelpful. But sometimes it may be helpful to determine if there are other lesions. So obviously if it's part of a wider pattern of disease, then we can be much more confident in determining what this specific lesion is. And finally, my top tip is SPECT CT comes with a CT component. So for those of you that do non-nuclear medicine imaging as well, and you probably already would think about doing this, but if you come across a lung nodule or something like that, and you want to know if it's been there before, you can often go back to a bone scan or a PET CT or something like that and see whether or not it was present on the CT component previously. And this young man with antiphospholipid syndrome, the clinicians were fairly confident he had adrenal insufficiency, but we reported this CT as bilateral adrenal nodules, likely adenomas. But if you go back to the bone scan 2 weeks earlier, where there was a CT component, these lesions weren't there. So this has to be bilateral adrenal hemorrhage. This can't be bilateral adrenal adenomas. And thank you for listening to me. And these are some of the references. Thank you very much.
Lovely, brilliant. Thank you for two excellent and really informative talks. They really did give some food for thought. We have had a few questions put through in the Q&A, which is brilliant. So I'll start off with a couple we've got for David. So Sarah asked, do you share learning with other departments such as radiology? I'd imagine that there are similar themes.
Yeah, that's a really good question. So some of the cases that we discuss, particularly the reporting cases, do get discussed in the radiology realm as well, if there is some learning to be had. But we don't currently particularly share learning from some of the non-reporting cases, which is something that I think there is potential for, because as you say, there are definitely similar themes, particularly around vetting, and some of the errors that happen is the first kind of area that comes to mind. So yeah, no, that's something I will take away and think about how we can do that with radiology and or more widely.
Lovely, thank you. And we've got another question from Henrietta. So at the meetings, what is the breakdown of how many people from each job role? For example, 5 techs, 1 admin staff. And do you have a maximum amount of each to make sure everyone's represented?
We don't have a minimum or maximum. As I said, we try and tag it on to some of the nuke med training days at which most of the kind of techs and physicists are at anyway. So we try and get as many people there as we can. We've got 3 nuke med radiologists in our department. At least 2 of us try and get there. Usually most of the techs, sometimes we get some of the PET-CT reporting radiographers that come along, the PET-CT scanning radiographers, sorry. We try and get the admin coming along, we get a couple of physicists, but we don't kind of limit it. It's not like we're trying to be core, we're trying to be as inclusive as we possibly can by including as many people as we can.
Just a quick question from me, actually, David, as well. Did it take some time for people to feel sort of confident to be able to escalate and engage with the process? And have you got any tips on how you encouraged that engagement?
It did, definitely. As radiologists, we're relatively comfortable with the concept because, I mean, I've grown up with Realm. It's been a part of the process for reporting as long as I've been a radiologist, really. But yeah, there was definitely a bit of skepticism in the early days about why we wanted to do this. But I think after we'd had a couple of meetings, that was replaced by enthusiasm and interest. And goes back to that point I made about setting the culture and making it all about the learning and trying to be inclusive and maintaining that anonymity, not blaming anyone, really focusing on what we can learn and to try and prevent those errors. One of the, I think it was the RDAs, said to me, it was really reassuring to hear that doctors make mistakes too. And that for me made the whole process worth doing, because that part of the reason why we wanted to do it, to kind of try and flatten some of that hierarchy.
Lovely, thank you. Great. So
sorry. Yeah, please continue. Yeah.
Sorry, Sabina. So I've literally got a couple of questions that come through for Emma as well. So one of the questions was, what could you have done differently with the right femoral lesion that was suspected as a MET? They'd have done the same thing, which is worrying.
Yeah, no, I completely. I think the problem was we were quite definitive about what it was. So when we did the bone scan, we said it could be a MET, it could be something else, do some additional imaging. But the problem then was that the additional imaging was very definitive and didn't give any room for error, whereas it even on the MRI, it was just indeterminate. And actually, whilst you do get a periosteal reaction with METs, what we probably should have done is raise the possibility that it could have been something else. And when we followed it up, the part of the problem is when you get the next request form just says metastatic breast cancer, and you don't bother to look to see whether or not that's correct. You assume that the clinical information is correct, and you've got a previous report that says it could be, so you just sort of assume that whoever's done the report of the MRI has also spent their time. But so we're propagating this error. So what we should have really done was just been a bit more, it could have been something else. And then when we followed it up, we could have said, it's not really typical. We've just got a single lesion that's just getting bigger, despite the fact it's being treated. And then we could have questioned it some more and done some different imaging and maybe gone down a different route. And maybe at that point gone, oh look, she had a raised CRP and she had a temperature and we didn't know where that was coming from. Could that actually have been infection just much earlier on? So yeah.
So just to comment, it's really excellent case, and thanks for sharing. And I guess, as you just said, probably at the point when was progressing in spite of treatment and no new meds developing, there could be just red flag, thinking something else is happening. But, as you said, at the beginning you were indeterminate and the uptake wasn't particularly hot anyway. It was like quite low to moderate grade, non-focal, so it wasn't typical. But it's excellent case. I mean, sorry for patient, but and it's quite difficult. I had a case which patient didn't want us to share at all, and patient's family didn't want to share later on. Although actually we have a sort of in NHS sort of blank rule that we have a verbal consent for images. But when you come from family, once when patient passed away, that it cannot be shared, that's quite difficult situation. I mean, it wasn't like case related strictly to nuclear medicine, it was more radiology and something about liver disease, which was assumed to be liver cirrhosis. and patient was started treating as an alcoholic when it was actually metastasis from neuroendocrine tumor. And it's just like how features on imaging can be quite difficult to interpret, particularly if you have an unusual presentation and you don't have all clinical information taken into account. So thank you. It was brilliant talk and from both of you. So I think we'll continue with the questions from chat, and then probably we'll go back to our questions, Tristan, because I'm sure that we also have quite a lot of questions.
No worries. Yes, I've got another question here. So do you ever check other reports for audit, and do you think that would improve accuracy?
Yes, possibly. There was at some point the RCR gave guidance to suggest that 10% of reports should be audited, but I probably, like most people, we don't really have time to report what we've got, let alone to then audit on top. And because it's not part of our when we've just set up reporting radiographer, a really good team of reporting radiographers, not for nuclear medicine, but as part of that, they came to me to talk about how, what sort of things they could put in place, and I said the one thing you should put in place is audit. So they've put audit in to start with, and I think that's really helped them. We do double report stuff, and if we're uncertain, then we double report, but that doesn't mitigate against us just missing stuff. The theory is that a lot of this goes to MDT, so your 10% will get picked up in MDT, but actually I think with nuclear medicine that isn't always the case. And because we're a very small department, the other problem we have is there are certain studies that only I report, so there isn't actually anybody in the department that can audit me, and other than me. And whilst I may still pick up my errors, and we often do. So, like for example, with whole body MRI, we started doing that with my colleague and I, and we double reported it. And what we would always, every single occasion, find something that the other person hadn't identified. And when we followed them up, we would usually find something again, because there's just so much information. It's hard to pick everything up in one go. Sorry, did that answer the question?
Thank you. Sabina?
I just want to talk about PET-CT, which is the only modality which is actually audited as a standard, which is sort of directed by NHS England as like a 10% of reports. And that's for the phase 1 and phase 2. And more recently, during one of the meetings, we were told by NHS England they will stop it, and they will for the next tender. And because exactly what you said now, that there is not enough time even to do like first reports, nevertheless, like to audit 10%. I mean, college probably recommends 5%, but we don't have systematic auditing for CTs, for MRIs, and they actually no performing any better than CTs of what we see on at MDMs. With PET-CT, fortunately, there is no really high rate of major discrepancies which are actually affecting management of patients that are categorized as 1 and 2. But most discrepancies are 4 and 5 or 3 when you're just missing something, but it would not influence to patients' care dramatically. However, the problem with that audit is that results come very often very late when the treatment's been already done, management's been done. So audit can only be affected for teaching, learning purposes, and also if it's done timely. So if you actually have it's good for learning, but for patients you might miss critical point. So it's best to really learn and continue learning and to try to prevent these discrepancies or errors. But we do have to factor on a human error. And just coming back to something what David said, it's very reassuring to see that doctors can make mistakes, but traditionally it was very worrying that doctors can make mistakes, particularly for patients who are looking from outside, thinking, you know 100% everything, while we know that medicine is often not white and black and quite often gray. So I think these meetings are fantastic for us to learn and to try to prevent errors for the future. But also, I just wanted to ask both of you, how often do you present teaching cases that are truly just for teaching rather than for discrepancies?
So in our case, it's probably about 25% now. We often get asked, can you talk us through parathyroid imaging in general, more as a teaching case rather than reflecting on a particular error. At the last one, I think it was talk us through shunt studies with VQ. So that has become an increasing part of it and is equally valuable in sharing that knowledge across different team members.
Yeah, I couldn't give you an exact percentage of, but I use a lot. If anything where I think that's a really nice example, and I've asked everyone to just hand them to me. Anything where it's a good example, we put them in to our meeting. I think they're really useful, as you say.
Great. You had you did illustrate that today as well with your cases that you presented. Thank you, Emma. So Tristan, do we go to continue with the questions from the chat? And
so I think we've got two more questions left, which should take us nicely to the end, I think. We've got one here for, I assume, for David, about how do you collect feedback anonymously into your meetings?
So anyone can submit a case or a question or query anonymously. We have a team spreadsheet that the team just add things to between meetings, and then I kind of tend to share it. So I collate the cases that we've had submitted either via email, which is a bit less anonymous. But yeah, adding things to a team spreadsheet is pretty anonymous, and that seems to work quite well for us.
Lovely, thank you. And we've got a last question here is how are your cases selected for your realm meetings at Bath?
So yeah, they're all submitted, linked to the previous answer really, all submitted by all members of the team. And we get cases from all the different professions represented. Often it's the technologists, but yeah, the radiologists submit cases. The admin team have submitted cases. The physics team particularly have started to submit questions where there's good learning to be had from a physics perspective. So yeah, we get cases from everyone, which is great.
Great. Unfortunately, coming to close this meeting, and I just want to thank you all our panelists. That was fantastic. Sorry that we didn't have more time for more questions, particularly I know Tristan had quite a few questions as well, but maybe we can continue talking the BNMS next time. And I just want to invite you all for next BNMS webinar on 13th of January, which is the first in our series with the past president webinars celebrating our achievements and looking for the past, present, and shaping the future. So I also wish you all really fantastic holidays and season greetings to all nuclear medicine community. And I look forward to seeing you in January and also for next webinar in our series after past president webinars in May for DEXA reporting. So good night and see you soon.